Hi, my name is Bhavik Patel, and in this lecture we will be discussing neonatal brain injury. I have no relevant disclosures. So here's an overview of the lecture. We will be discussing hypoxic and ischemic injury in neonates. We will be discussing neonatal seizure as it relates to hypoxic ischemic injury, as well as intraventricular hemorrhage and traumatic intracranial hemorrhage in neonates. These are important topics for neurosurgeons and neonatal intensivists alike, as well as pediatricians, because these injuries tend to create a large burden of morbidity and mortality in the neonatal population. The first topic of our lecture is hypoxic ischemic encephalopathy. This has an incidence of approximately 3 to 5 out of 1,000 patients. The mortality associated with it is approximately 10 to 40%, and the morbidity, primarily neurodevelopmental delay, is approximately 33%. The pathophysiology of hypoxic ischemic encephalopathy is broken down into two phases. The first phase is primary energy failure, and that occurs as a result of exhaustion of cellular metabolites and sodium and water influx into the cell. This is an immediate injury, and it is followed by a latent period of approximately 7 to 12 hours. Subsequently, we have a secondary energy failure, and this is a result of calcium influx via excitotoxic glutamate receptors. This causes an activation of lipases. It causes nitric oxide synthesis and free radical injury, and it causes cytotoxic damage from activated microglia. And this all results in mitochondrial injury and cellular apoptosis that occurs over a period of hours to days. As I mentioned before, this is a delayed injury that occurs after a latent period. It confers the majority of the injury associated with hypoxic ischemic encephalopathy, and it is associated with worsening encephalopathy and onset of seizures in the patient. The diagnosis of hypoxic ischemic encephalopathy is made on the basis of several criteria, including a gestational age greater than 35 weeks, a subnormal level of consciousness or seizure, and evidence of a peripartum or intrapartum event. And these peripartum or intrapartum events could include an APGAR score less than 5 at 10 minutes, or a cord pH less than 7.0, or a base deficit higher than 12 millimolar per liter, as well as magnetic resonance imaging and spectroscopy findings consistent with acute brain injury and evidence of multi-system organ failure. Sentinel events can contribute to hypoxic ischemic encephalopathy, and these include a ruptured uterus, severe abruption, or an umbilical cord prolapse or maternal cardiovascular collapse. The severity of hypoxic ischemic encephalopathy varies from mild to moderate and severe, and is defined by a variety of factors including level of consciousness, spontaneous activity, muscle tone, posture, primitive reflexes, and autonomic function. The patterns of brain injury in hypoxic ischemic encephalopathy can reliably predict the outcome. Deep nuclear gray matter injury, as seen in this T1-weighted MRI scan, involves injury to the basal ganglia, the globus pallidus, and the thalamus. This is associated usually with an acute catastrophic hypoxic or ischemic event, and usually results in a dyskinetic form of cerebral palsy. In contrast, injury to watershed areas is associated with repetitive, milder hypoxia and ischemia, and is associated with a more favorable outcome. This is shown in this diffusion-weighted MRI scan here, where you can see diffusion restriction in the watershed areas, which are the areas between the blood supply of major vessels such as the middle cerebral artery and the anterior cerebral artery. Lastly, there can be global injury, which also involves the brainstem, and this is associated with a very grave prognosis. The workup of hypoxic ischemic encephalopathy involves close observation. In mild and moderate encephalopathy, the exam can fluctuate quite a bit. EEG monitoring for 24 hours is also recommended, as the incidence of seizures is quite high in patients with hypoxic ischemic encephalopathy. And MRI without contrast or sedation at 4 to 7 days of life is also recommended. And many hospitals have developed rapid protocol MRI scans that allow acquisition of good quality imaging. The treatment for hypoxic ischemic encephalopathy can vary. One of the mainstays is therapeutic hypothermia, and this involves whole body or head cooling initiated within 6 hours of life. The target core temperature is 33 to 34 degrees centigrade for 72 hours, followed by rewarming that occurs over a period of 6 to 24 hours. The temperature is measured either with an esophageal or a rectal temperature probe, and rewarming occurs in a slow, gradual fashion. During the cooling period, patients may be administered morphine for shivering and sedation, and the outcomes with therapeutic hypothermia are improved with a reduced death and neurodevelopmental disability at 18 months in some studies. However, there are some side effects, and these include sinus bradycardia, hypotension, and thrombocytopenia. Occasionally, the hypotension requires inotropic support, but this is not always seen. Neonatal seizure is our next topic of discussion. This has an incidence of approximately 0.1 to 0.5% in neonates, and seizures are more commonly seen in this period of life than in any other period of the human lifespan. High-risk conditions associated with neonatal seizure include hypoxic ischemic encephalopathy, central nervous system infections, intracranial hemorrhage, inborn errors of metabolism, perinatal stroke, and genetic diseases with CNS malformations. Seizures are associated with an adverse neurological and cognitive outcome. And approximately 50% of neonatal seizures in term infants are secondary to hypoxic ischemic encephalopathy. Importantly, the incidence of seizure in hypoxic ischemic encephalopathy is significantly reduced by institution of therapeutic hypothermia. The diagnosis of neonatal seizure can be quite challenging, as clinical detection is very difficult. Approximately 50% of neonates with sustained ictal discharge may have no clinical manifestations. Seizures do not typically manifest with generalized tonic-clonic activity as seen in adults, and this is largely due to incomplete myelination of the corticospinal tract and a higher threshold for secondary generalization in neonates. Amplitude-integrated EEG allows for early diagnosis and treatment of neonatal seizures without an EEG technologist support. And you can see an example of that in this tracing right here, where you have a traditional EEG tracing above and an amplitude-associated EEG tracing below. Here at this arrow, you can see initiation of a seizure in this neonate. The first line of treatment for neonatal seizure is phenobarbital, with the second line being fosphenytoin. There are other anti-epileptics that have been previously used and investigated, but don't have good evidence in the literature at this time. And these include levetiracetam, or Keppra, which has not been well investigated in neonates, but is used on occasion, lidocaine, which is commonly used in Europe, and Versed, which has varying efficacy and is sometimes used in addition to other anti-epileptic agents. The outcomes are dependent on the detection and treatment of seizures, and early detection and treatment reduces the seizure burden and post-neonatal epilepsy. Most seizures secondary to hypoxic ischemic encephalopathy stop within 72 hours, and maintenance anti-epileptic therapy is often not indicated. Our next topic of discussion is intraventricular hemorrhage. Germinal matrix hemorrhage with associated intraventricular hemorrhage is the most common hemorrhagic brain injury in preterm infants and occurs usually within 72 hours of birth. There are 4 grades of germinal matrix hemorrhage. Grade 1 hemorrhage is hemorrhage confined to the germinal matrix itself, which you can see in this ultrasound here, with this arrowhead pointing to this small cystic lesion here. Grade 2 germinal matrix involves extension of the hemorrhage into the lateral ventricles, but without ventricular dilation. And we can see that here in this ultrasound, where you can see bilateral areas of hyperechoic blood that has extended into the ventricles. Grade 3 germinal matrix hemorrhage is extension of the hemorrhage into the lateral ventricles, but with associated ventricular dilation. And you can see that here on this ultrasound, where the ventricles are more plump than the acutely shaped ventricles in grade 2 hemorrhage. And lastly, grade 4 germinal matrix hemorrhage is associated with intraparenchymal hemorrhage. And you can see that in this figure here, where there is hemorrhage extending into the cortex on this ultrasound. To understand the burden of morbidity and mortality associated with intraventricular hemorrhage, we first have to look at some epidemiology. Preterm birth, which is defined as birth at less than 37 weeks gestation, occurs in 9.6% of all births worldwide. It causes 28% of neonatal death not related to congenital malformation, and the highest rates are in Africa, where there is a 12% incidence, and North America, where there is an 11% incidence. The cost burden in the United States is estimated to be greater than $26 billion. And the preterm birth statistics in the United States are driven by rising rates of early induction of labor, cesarean delivery, multiple gestations, and increased survival of affected infants. Intraventricular hemorrhage occurs with increased incidence with decreased birth weight and gestational age. There's an incidence of 36% of intraventricular hemorrhage in very low birth weight infants, which is defined as infants weighing less than 1,500 grams, and an incidence of 38% in infants born at 22 weeks gestation, compared to just 7% at 28 weeks gestation. Post-hemorrhagic hydrocephalus is a well-known complication of intraventricular hemorrhage, and its incidence increases with increasing grade of intraventricular hemorrhage. There's a 1% incidence in grade 1 and 2 intraventricular hemorrhage, an 18% incidence in grade 3 intraventricular hemorrhage, and a 29% incidence in grade 4 intraventricular hemorrhage. Furthermore, infants requiring a shunt are at a higher risk for cognitive and motor impairments, including cerebral palsy, neurodevelopmental impairment, and lower mental and psychomotor development indices. The germinal matrix is located in the ventrolateral aspect of the lateral ventricles, along the thalamostriate groove, posterior to the foramen of Monro. It progressively involutes to obliteration at 36 weeks of gestational age, and this explains why germinal matrix hemorrhage is associated with preterm delivery. Germinal matrix is an area of proliferation of neuroblasts and glial progenitor cells. It is a highly vascularized structure with arterial branches from major vessels, including the internal carotid artery, the anterior cerebral artery, and the middle cerebral artery. Predominantly, these branches include the recurrent artery of Hübner, the anterior choroidal artery, and the lenticulostriate arteries. And these form vulnerable capillary beds with primitive endothelium and no surrounding connective tissue. This leaves these vessels friable and vulnerable to systemic variations in cerebral blood flow and pressure. And the hemorrhage that occurs at the capillary-venous junction. These vessels are vulnerable to peripartum hypoxia, birth trauma, and essentially any neonatal stress. Periventricular hemorrhagic necrosis represents venous infarction due to obstruction of the medullary and terminal veins. And so this is not simply an extension of germinal matrix hemorrhage into the parenchyma, but rather represents the result of venous infarction. The hemorrhage follows a distribution of medullary veins that funnel into the bilateral terminal veins, which then run through the germinal matrix. The terminal veins then empty into the internal cerebral veins and the vein of Galen. The management of intraventricular hemorrhage relies on several different principles. In the case of germinal matrix hemorrhage with resultant intraventricular hemorrhage, prevention with corticosteroids administered antenatally has been found to be quite effective. The mechanism of this is unclear and may relate to angiogenic inhibition and stabilization of the germinal matrix vasculature by corticosteroids. Steroids may also reduce variations in blood pressure. Other medications and drugs have been investigated but have been found to be ineffective, and these include administration of vitamin K, phenobarbital, muscle paralysis with pancuronium, and indomethacin. The diagnosis of intraventricular hemorrhage can be made on the basis of clinical exam and imaging findings. Typically, in patients who are preterm and weigh less than 1,500 grams, a head ultrasound within 48 hours should be obtained. Other imaging modalities that are available include CT scan, which should generally be avoided as it exposes the infant to radiation during a period of particular sensitivity and fragility, an MRI scan, which often is less accessible than head ultrasound. Monitoring of the infant involves daily occipital frontal circumference along with a physical exam. The physical exam should include palpation of the anterior fontanelle and sutures. The tenseness of the anterior fontanelle and splaying of the cranial sutures is crucial to detecting developing hydrocephalus. The transition to a bulging, tense fontanelle can be appreciated on examination, and splaying of the sagittal suture more than 2 millimeters in the mid-parietal region has been shown to be a reproducible physical parameter in monitoring for developing hydrocephalus. Other signs and symptoms typically associated with hydrocephalus, including lethargy, vomiting, and impaired upgaze, may be absent or difficult to appreciate in critically ill infants. Lastly, serial ultrasound imaging can be very helpful in detection of developing hydrocephalus. Once enlarging ventricular size has been detected, a neurosurgical consultation should be obtained. Diuresis and intraventricular thrombolysis has been previously investigated and is not recommended at this time. The efficacy of lumbar puncture for reduction of ventricular size and intracranial pressure is equivocal, and there is a wide variety of clinical practices with regard to neurosurgical interventions. In patients who cannot tolerate a larger surgery, temporizing measures can be employed, and these involve placement of a reservoir, placement of a ventriculo-subgaleal shunt, or an external ventricular drain if necessary. Once it is determined that the infant can tolerate a surgery and that definitive surgical management of hydrocephalus is necessary, depending on the cause of hydrocephalus, ventriculoperitoneal shunting or endoscopic third ventriculostomy in select cases can be employed. All surgeries are prone to complications such as infection, scalp erosion, and malfunction requiring revision in the case of reservoirs, shunts, and external ventricular drains. And even with appropriate neurosurgical treatment, preterm infants with intraventricular hemorrhage who require a shunt tend to have poor outcomes, as previously mentioned. In this image here, we can see that a ventricular catheter has been placed in the lateral ventricle of this infant. Our last topic of discussion in this lecture is traumatic intracranial hemorrhage. The overall rate of birth trauma has declined, but approximately 2% of singleton vaginal deliveries and 1% of cesarean deliveries are associated with birth trauma. The rate of intracranial hemorrhage associated with birth trauma has also similarly declined, but is not insignificant, with 0.03% of spontaneous vaginal deliveries, 0.2% of combined vacuum and forceps deliveries, and approximately 0.3% of cesarean deliveries after failed instrumented vaginal deliveries being associated with intracranial hemorrhage. The risk factors for intracranial hemorrhage include forceps or vacuum delivery, even in trained hands. And this used to be an area of controversy in the past, but multiple studies have since shown that in fact these methods are associated with an increased incidence of intracranial hemorrhage. In addition to this, macrosomia, maternal obesity, and precipitous delivery have also been associated with an increased risk of intracranial hemorrhage. Traumatic intracranial hemorrhage can occur in various sites. Hemorrhage into the epidural space can result from shearing of the middle meningeal artery. However, this is uncommonly seen in neonates as the meningeal arteries are not embedded in the bone as they are in adults and are therefore less vulnerable to this type of injury. Shearing of cortical or bridging veins can result in subdural hemorrhage, and avulsion of small leptomeningeal veins can result in subarachnoid hemorrhage. Intraparenchymal and intraventricular hemorrhage can also be seen in the setting of birth trauma. The diagnosis of traumatic intracranial hemorrhage can be difficult. Increases in intracranial pressure are attenuated by the fact that neonatal sutures are open and the fontanelle is open. Symptoms of elevated intracranial pressure include irritability, a raised or tense fontanelle, and splayed sutures. Head ultrasounds, CT scans, or rapid sequence MRI scans are crucial in the detection of traumatic intracranial hemorrhage. During the workup of traumatic intracranial hemorrhage, it is important to rule out other causes of intracranial hemorrhage, and these include congenital coagulopathy, thrombocytopenia, or congenital tumors. Typically, traumatic intracranial hemorrhages are managed expectantly. Rarely, a craniotomy is necessary for drainage of the hemorrhage. Occasionally, intracranial hemorrhage can result in seizures, and as previously discussed, it is important to manage these seizures with appropriate detection and anti-epileptic drug administration. That concludes this lecture on neonatal brain injury. I'd like to thank my co-contributors, including Ashwin Kamath, Amit Mathur, and David Limbrick.